Hello and good afternoon. This is Kim Kuebler, Editor-in-Chief for the Multiple Chronic Conditions Resource Center, and we are happy to announce today Irina Koyfman. Dr. Koyfman is an adult nurse practitioner and doctor of nursing practice from Johns Hopkins School of Nursing. She has been in the nursing profession for 25 years. That includes 15 years of executive experience. Dr. Koyfman is an expert in the patient-centered medical home, home healthcare, healthcare startups, transitional care, community health, chronic care management, remote patient monitoring, and care coordination. Dr. Koyfman has established 4 successful healthcare ventures where she drove significant operational growth up to 1,000%. She has built successful teams with high retention rates and improved patient satisfaction and patient outcomes. She is considered a subject matter expert in chronic care management and remote patient monitoring, making her a requested speaker for many national conferences. She is the founder of Affinity Expert, a healthcare consulting company that has been consulting with primary care practices on the implementation of these reimbursement models of care. She has created a growing community of clinicians through her Facebook and LinkedIn interfaces where she provides free provider information and education. Welcome, Dr. Koyfman.
Thank you, Kim, very much, and please call me Irina.
Okay. There's a lot of buzz talk about the chronic care management. Can you help us understand what that means by giving us maybe a brief description and how this can be used in the primary care setting?
Sure. So chronic care management, or CCM as it's known, was developed by Medicare in 2015. Basically, Medicare, I think, actually heard the providers who were saying, look, this is very fee-for-service business. We're not getting paid when we are doing all this work outside of our office visits, when patients are calling us back and they wanted to understand again why LASIK was increased, or when they needed a walker and we needed to send them for DME, or when they need pre-authorizations, all the stuff that we do, we couldn't bill for it. Medicare finally heard the providers and they said, fine, we're going to create this one code. It's going to call chronic care management, 2 codes. CCM and complex chronic care management for 20 minutes or 60 minutes based on your involvement per month, and we're going to pay you provider for taking care of everything that has to do that happens in between your office visits. So it sounded great. As usually there are always early adopters. Some doctors and Ps kind of jumped on the bandwagon, but it was pretty complicated. I mean, it still is, but it required a written consent. So you couldn't just enroll patient in. You had to talk to the patient, have them sign a consent, because billing happened through Medicare, right? So Medicare has to pay for it. Then there's a coinsurance. So you have to explain to the patient possibly cost sharing, what the program entails. So as you can imagine, it's not a big rollout, because how many patients can you see per day and actually talk to them and have them sign a consent? Okay. Then it's pretty detailed care plan, which still exists. And then you had to learn how to actually, not only bill, but it's billed per time. So it's 20 minutes increment. Well, how do you capture the 20 minutes? Right? So there was no softwares to say that they did that. So people use Excel spreadsheets and they said, oh, I spent 8 minutes on the phone with the patient. So it kind of, I would say, died out. But by 2017, Medicare had data, and they love data. So they looked at every patient that was billed for the CCM code, and what they found was that patient satisfaction was higher, provider satisfaction was higher, and of course, what is the most important thing for Medicare? Their total global cost of care was lower. So they were like, oh, we think it's working. So by 2019, they made a lot of changes. It was pre-COVID. They did not know about COVID. But by 2019, they added other codes, like you could bill now 20 minutes and then another 20 minutes and then another 20 minutes. Before, it was only 20 minutes or 60 minutes. So if you spend 40 minutes, you could only bill for 20. So they added a lot more codes. And they also heard from the specialist like you, Kim, who said, well, what about me? I'm only treating, let's say, pain or, arthritis, but chronic care management is, all of the diseases. So they said, okay, well, specialist, now we're going to design a code for you that's called principal care management. So it's a cousin or brother of CCM, just for when you're dealing with one condition. And that was great. And then the biggest change happened in 2022 when Medicare actually increased fee schedule for CCM by about 50%. So imagine every year they're slashing and slashing and slashing, and now they're like, oh, we're actually going to double it. So it went from an okay reimbursement of about $40 to $64 national average for 20 minutes. So then it became super, lucrative, a lot more providers started doing it. But basically what CCM is, and to answer your question that you asked, is it was designed to manage people with 2 or more chronic conditions. So a patient has to have a Medicare, obviously, and again, a lot of private insurances did pick it up, but I'll just say Medicare because it's easy. Medicare, what starts everything. So they have to have a Medicare. They have to have at least 2 chronic conditions, and they have to agree to participate. On the provider side, you have to actually have a lot more in order to participate and bill for the program. You have to have an EMR, which, I was laughing until I actually met a clinic in my own state who decided not to ever use an EMR when it happened. They're still using paper and pencil, so they do exist. The dinosaurs do exist, so they can't bill for CCM. You have to have an EMR. You have to have a 24/7 coverage. It doesn't mean you, Kim, need to be on call 24/7 if you're billing provider, but you have to have a coverage for people to know when to call and how to get to somebody. And you should have a dedicated team member for the patient, meaning that you don't want to just do the CCM and anybody in the office can just pick up a chart and do something. You really want to have a designated team member. So there are some things on the provider side, some things on member side, but what I can tell you is that because the reimbursement rate went up so much and there are a lot more codes, that CCM really exploded. And every year I'm seeing data, more and more providers are billing for it, which means more and more patients are taking advantage of these services.
So it is a Medicare incentivized reimbursement for these patients with 2 or more chronic conditions.
Correct.
Okay.
Yes. Right.
And so when you say that they're saving money, it's kind of like care coordination, right?
Right.
So is it preventing patients from going into hospital?
So great question. I haven't seen any data particularly to say exactly where the cost is being reduced. However, we both know that the major cost for patients is always hospitalizations and readmissions. So, we can take a guess and say, yes, less people are using hospitals, less people are getting admitted, less people are using emergency rooms because they're getting a lot more extra layer of support by your clinical staff. So I think I have to go back and explain a little bit what is chronic care management, because now we know that there are codes and there are 20-minute codes, but what does it mean? Like, what do you do in the 20 minutes? My answer is, it's anything you do for, with, or on behalf of the patient that does not require face-to-face communication. So, and you can do face-to-face, but obviously nobody's going to do this because you're not going to get a patient to come to see you and bill for CCM, because if they're coming to see you, you're billing for a visit. So basically, it's any type of care coordination, care management. So think about it. The only thing that you should not include in CCM timing is actually filing or faxing something, which is kind of arbitrary that I've found in a very small print from Medicare. But so let's take an example. You have a patient, the patient now verbally consented to participate in the program, because that's another change that Medicare did in 2019. They said, okay, fine, we'll just do verbal consents, which made the program much more easier. Because now you can call and talk to 30 patients a day very easily and have them to get consented, but you're not going to be able to get them into the office that fast. So verbal consent, patient agreed, you write a care plan. What's important to know is even though only 2 chronic conditions, patient has to have 2 or more chronic conditions in order to be eligible for you to bill for CCM, your care plan has to include all of their conditions, obviously, because you don't want to just say, and a lot of providers do, and that's a big miss, I think, on their part. But let's say your patient has diabetes, CHF, arthritis, asthma, obesity, and you'll say, I'm only going to do care plan on CHF and diabetes. Well, then you're missing out on all the other things because, as you said, like, what is the purpose of CCM? The purpose of it is to help people, hopefully, not get admitted and not get readmitted. So that extra layer of support, you want to be able to understand the care plan should have all of their chronic diseases, all of their medications, all of the coordination of care, and then anything you do for the patient. So, a lot of it is education. Nurses call every month and maybe they go over red flags. You have a CHF. Let's talk a little bit about low sodium diet. How much salt are you eating? You'll be surprised how much people they're not doing certain things, sometimes due to lack of understanding, which is very clear. I've had patients who were like, I eat so healthy. I eat literally salads and grilled chicken. And my blood pressure's through the roof. When we actually sat down and went through everything, well, they love pickles. So pickle goes with every chicken that they eat. They added a lot of salt to the salad. And they were like, oh, well, I did not know how much, pickle and high sodium food plays a role. So that's that's lack of understanding. This is where CCM plays a huge role. But another one, of course, is lack of resources, right? You can tell a patient don't eat chips until you blue in the face. But if their next store that they can actually walk to is 7-Eleven and one apple is $1 or bag of chips is $1, what are they going to pick? So then big part of CCM is also helping people with the resources. So social determinants of health, really understanding what their issues are and setting them up. So, Meals on Wheels, transportation, medication delivery. So everything that your clinical staff can just take their time, take a breather and be like, look, wow, I actually get paid for doing this. They feel amazing because when they talk to the patient and they can understand what the issues are. And it's also important to ask the right questions because I had a patient in the hospital where there was a question as to why, like, she wasn't coming to an appointment and she wasn't picking up medications. And then everybody was like, oh, it must be transportation. So the question that was asked of her is, do you have a car? And she said yes to many people, the social worker, the doctor, the nurse. When I came in and my job was to prevent readmissions, I've learned to look at patients from the lens of what's going to bring you back. So I was like, if transportation seems to be a problem, she said she has a car. I need to dig deeper. And because she usually said, well, I can't get to the doctor because of transportation, but do you have a car? She said, yes. So I asked her, I said, I say that you have a car. Do you drive your car? And she was like, oh, no, honey, that's an old broken car. It's been in my garage for 10 years. She didn't lie. The question was, do you have a car? She has a car. She did not link the question to, are you using the car to get to your doctor's appointment? So it was such an easy fix. So this will give your clinicians, and not doctors and nurse practitioners, but your clinical staff that you'll hire, your nurses, your LPNs, your MAs to work with you with patients, is to be able to ask those questions. How do you get to the offices? Well, I don't have a car. It's getting hard for me to take a bus. Okay, well, let me see by the way, I did not know, Kim, but Meals on Wheels provide transportation to doctor's appointments. I did not know that until I got into this. And then I started using this amazing website, no relations, that's called findhelp.org. It's a huge, big nonprofit where if you go in and you just put in your zip code, and it's so easy to use, and you'll say what it is you're looking for. Are you looking for, food or transportation or gym membership? It was designed for the social determinants of health. So they'll show you everything free that it has within that zip code. Churches have food pantry. It will say, this church is 2 miles away. There's a food pantry every Thursday from 9 to 11. It's an amazing website to use. And that's, again, big part of CCM is to understand what people are struggling with. But then it's like you don't want to diagnose without having a solution, right? It's worse than not knowing the diagnosis. It's worse having a diagnosis and not being able to do anything with it. So you diagnose the problem and then you work on a solution to help people get better, healthier. And I think, again, to back to your question, is I think that's how Medicare is saving money, is because CCM is bringing that much extra layer of support to people so they don't end up hospitalized because they didn't come to you, they couldn't get their medication, and it's only because they don't have a car.
Right. Well, we just published a paper on integrating palliative care in patients with multiple chronic conditions, with the whole focus being on using symptom management, a form of palliative care to reduce exacerbations. So that was kind of my question, if you have patients with heart failure or chronic obstructive pulmonary disease, we know that they have frequent exacerbations that take them into hospital. So my question is, you talked about the specialists that can also participate in this incentive reimbursement through CMS, primarily Medicare. How does the primary care provider maintain a continuity within the CCM if a specialist is also seeing that same patient?
Wonderful question, and great question. So CCM was designed for primary care. Part of provider responsibility is to maintain the care plan, to share it with the specialists that are involved in the care. So have that communication. Principal care management, which was designed PCM for the specialist. So cardiologists can bill for PCM for the same patient while primary care is billing for CCM, meaning that it's not one or the other. You don't have to pick and choose that, cardiologist is taking care of CHF, so now I'm a primary care, I can do CCM. So cardiologist can do PCM, and his job is also to make sure that you as a primary care have that care plan, and the communication is going back and forth. To be honest with you, how is it really done in real life? It's tough and it's hard, and I'm not going to sugarcoat it. Do clinicians, your clinical staff, are they picking up the phone and calling cardiologists for, questions? Probably not. However, if person is, admitted to the hospital and it's CHF, then my hope is that your clinical staff will work really hard with the clinical staff of cardiologists, because now both of your skin is in the game to make sure that person doesn't get readmitted. So that gives a lot more, I would say, time and money to maneuver, because before, when you had to call a cardiologist, that time came out of your pocket because you're not getting paid. You're calling cardiologist to find out something. Right now, it's all part of CCM. So your clinical staff, if you say, listen, call cardiologist, see when their next appointment is. I want to understand why patient was discharged on the same dose of Lasix. They can do all that and still bill for CCM. And so, again, my hope is that what's being done, and that's what it should be done. But, it's not as easy because a lot of providers still outsource this. So they have a kind of nursing staff calling from, somewhere else, and cardiologists somewhere else. So communication is not as seamless as I would like it to be. But specialists can bill for PCM, primary care can bill for CCM, and hopefully together they should be working, side by side to make sure that patient gets even more support.
So just so that I better understand this, as a primary care provider, I'm going to make a referral for my patient to be seen by cardiology for heart failure. Mm-hmm. Does that cardiac disease also, do I continue to evaluate that in my ongoing communication, or do I defer that to the cardiologist because we're both billing under the chronic care management?
I think there's ethical question and there's also legal question. Legal question is CCM and PCM are both kind of disease neutral, meaning that, for CCM, every disease is and you should be taking care of it. For PCM is whatever disease you're taking care of it as a specialist. And if cardiologist is doing CHF, you should do CHF as well. So like legally, you both should do it just like a primary care. Like you're not going to say, I'm not going to go over your CHF medications because you're still going to do it And then if you have questions, you might consult with the cardiologist to say, look, what's going on, whatever. And ethically, I think what a lot of people do is they say, oh, okay, so I'm not gonna include CHF in my care plan because cardiologist is doing CHF. I'm not gonna include diabetes because endocrinologist is doing diabetes. Like, to me, that's unethical because as a primary care, you're taking care of the whole patient. And even though you refer them to cardiologists and endocrinologists, you get their report, you integrate it into your primary care visit next time, and you have a communication. So I think both legally and ethically, everything should be done for the patient from every clinician, despite who's billing for what. And legally, you can bill for whatever you're billing for, despite what other PCM specialists are involved in care. Hopefully, I answer your question. It's a little convoluted, but it's.
No, you did. I mean, you did. I just wondered if there was any problems with reimbursement
No.
when you're using a specialist who's also using the specialty chronic care management incentive. So as far, I think that your perspective is more on the business side and setting things up, and mine is more from the patient perspective. As far as patients go, just having that 24/7 resource, I mean, that has to really make them feel secure in the care that they're receiving under this model.
Yes, I just wanted to clarify that 24/7 support is really not 24/7 because the nurses are usually not on call 24/7. The nurses usually work, their normal, business hours when they talk to patients and do things for patients. But the 24/7 support meant that as a provider, when you're billing for it, you have to have a 24/7 coverage that patient is aware of. So whatever your on call, like nothing changes, right? I think right now every provider, everybody have on call options. It's more about letting the patient know that those are available because some patients are not aware and they're like, oh, I know that my doctor, they don't take any phone calls after 5 and it's 5:45 and I'm having, whatever. I have a little bit of a anxiety and I don't know if it's my heart attack, if it's my chest or it's my anxiety, whatever. So I'm just going to go to the hospital. So, but they don't know that they should call and there's going to be a provider on call that can call them back and actually do their intake and then tell them whether or not they should go to the hospital. So it's more about like letting people know what options are. But I can tell you from patients' side, from patients that I talk to, they love having a dedicated person that they can call anytime. I mean, anytime within reason, right? Nobody's going to call at 2:00 to say, oh, by the way, I forgot when my next appointment is. 2:00 in the morning, I'm in. But they can call the nurse and they can talk to them and they can go over certain things. And you know how many times people leave your office and they probably feel stupid asking you the same question again, but they leave you assume that they got it because they asked a question and you answered, but they didn't get it. So they were like, oh my gosh, I feel stupid, I'm not gonna ask the question. And then they go home and they really don't know what medication they need to take or what. So having that nurse who already has access to the EMR, who can say, they can call and be like, look, I just saw my provider. I didn't feel comfortable or forgot. He told me that, I think that he's increasing my metoprolol to 50, but I'm not sure, like, what do I do with my 25? Do I take 25 plus 50? Right? And that's what happens a lot of times. People just, they're not clear on the directions. So they'll add the new dose on top of what they already have. Or, right? So that happens. And so having that, I think, gives people a lot more reassurance. It makes them feel more happy, satisfied. And I can say that from what I've seen, providers that do provide CCM, the patient satisfaction towards the provider is much higher.
Mm-hmm. I remember reading about CCM in the Federal Register. I think it was in 2016. I was very excited to see this incentive come in because it really is palliative care. I mean, it supports patients with multiple chronic conditions for sure. So what advice would you give a primary care practice or a specialty practice that wants to consider using this Medicare incentive reimbursement?
Yeah, so I can say that I'm also a big supporter and lover of remote patient monitoring, and hopefully we'll do another podcast on RPM. But I would say that if you're doing CCM already or PCM and you're not doing RPM, you're missing on a lot of amazing clinical data and information, and you're missing on financial incentives. So if you're doing it but you're not doing RPM, think about adding that. If you're not doing CCM, I always think of it as just leaving money on the table, and not to be so like blunt and, business only kind of, money drives business. It's not that. It's just that if you're not doing CCM, you're doing CCM. You are doing CCM. You're just not getting reimbursed for it because you're answering your patient's phone calls, you're writing for pre-authorizations, you're getting their walkers and DMEs, you ordering, home healthy, like you're doing it. But if you're not getting reimbursed, then you are leaving money on the table. It's coming out of your pocket. So my thing is, it's not that we're not doing it, but we don't know how to get paid. So that's why I became so passionate about it, and I started doing all these like free webinars and just letting people know, because I'm like, guys, like we always talk about how we're not getting paid enough for all we do in between the office visits. Well, here it is. Like, just learn how to do it and do it. So my big advice is do it. But before doing it, really do your research. Like you need to understand whether or not you want to do it in-house or you're going to hire a vendor. A lot of people hire vendors. I work for a vendor. Some vendors are amazing, some are not. So you really have to do your research. You have to understand how compliant they are, because they're going to bill under your NPI. They're billing under you. You're the billing provider. They're providing the care. How are you going to track quality? Are they actually talking to the patients? What needles are they moving? What's happening? So do a lot of that investigation. If you can, I think doing in-house is great, but it's not super scalable because it's very hard to find people nowadays, to work. So it's you don't want to add anything more to your staff already. You want to hire a new staff to just take it on. But it's so lucrative that if you think about it and do the math, $60 on average for 20 minutes, that's about $180 an hour. Think about how many people you can hire. And normally, care coordinator, in my mind, should be able to take care of about 350 patients on a monthly basis. So just you do the math. I'll leave it up to you. But it's very lucrative, and it's great to do it, I think, in-house, because these nurses, like, they'll know you. They'll know exactly when to ask you, when not to ask you. It's great. But vendors are also, some are fantastic. Just do your research, understand, meet with them, see who, I love that too. One time I talked to the nurse who came from another like CCM company, and I asked her why she left. She said, well, because they hired a manager, like whatever, manager we didn't see eye to eye. And I was like, oh. Well, the manager was a veterinarian tech. I almost fell out of the chair. I was like, vet tech to manage nurses? Like, and it's not, I'm not saying, if you're a good leader, you're a good leader. It doesn't matter who you're leading, doctors, nurses, or vets. But when we're actually talking about nursing care and care plans, I feel that nurse needs to lead a nurse. Like, you can't hire veterinary tech, and that's why she left. She was like, I can't ask any clinical questions. You want a manager that be able to answer your clinical questions as well. So do that research. And also, if you're hiring a vendor and they use their software, because softwares have clock built in, you can be very confident that every 20 minutes is counted. You wanted to understand what their fees are, because some will bill you per patient per month. Some will bill you just a much larger monthly fee, like $550 a month for the software, but it's unlimited patients. So you have to do a little bit of the math to see, where in the long run is it better for you to like pay, PMPM or like a monthly fees. But again, my big passion is I think everybody should do CCM. And just to leave on another positive note, Medicare just came out with their proposed fee schedule, which very soon they'll come out with the final for next year. They're proposing this brand new program that I think is going to blow everybody's mind. And I think CCM is probably going to kind of morph into it, where they're proposing that you as a provider can bill for every patient on your caseload, no time requirement. $10 per patient per month. If they have 2 or more chronic diseases, it's $50 per patient per month. And if they're a QMB, it's $110 per patient per month. Again, I don't know enough about it because they're going to come back with the final rule and let us know exactly what it is, but it's no time requirement. And I think it's Medicare way of, giving a carrot before the stick. Like they want everybody to move into value-based care. So they want to see more value that you bring to the patients. And so this is going to be their carrot. Like, hey, just start doing it and get paid. And right now we don't really care kind of what you do and how you do. But then I think in a few years, they're going to come back with the stick and say, just like EMR, like if you're not doing it now you're going to get penalties. So that's going to be, I think it's going to blow, people's mind, because imagine what you can do with that money, and you can hire somebody to actually work with patients, and you can, maybe do, the risk assessment, really high risk, rising risk, and put more resources. But I think it's amazing. And I applaud Medicare for really kind of doing, really moving into the value-based care.
Well, and value-based care, but also, patient-centered care planning in an age-friendly environment, right? So we have all these things that are coming at us. The chronic care management reimbursement through Medicare. I mean, I when I first saw it, I thought it was amazing, but I didn't see a lot of people utilizing it. Mm-hmm. And when you and I talked, you said that you do, but that's what you do. Right. You see people that are using it. So you mentioned the remote patient monitoring just real briefly, and we would certainly like to invite you back to talk more on that. But so you can actually get the remote patient monitoring and do the chronic care management reimbursement incentives together.
Correct. It's not mutually exclusive. And if anything, I do feel that they should go hand in hand. Because imagine if you have a patient that you have a care plan for, 7 of their diseases. One is hypertension. And now you're able to send them a home blood pressure machine where they can take a reading and you can see it in real time, real data. And you can now say, not arbitrarily when they come to you once every 3 months and you take their blood pressure, but you can say, oh, I can see that the blood, so I have so many patients where I was just able to change the timing of their medication, knowing that when I talk to them, let's say their blood pressure in the morning is really high, like 160/90, but then through the day, it's normal, 140, 130, 120. So then I talk to them. If I had seen them early in the morning, right in the office, I would be like, oh, we're adding another medication. But then I understood, oh, they taken 2 antihypertensives, but they taken them both at night. So, I'm sorry, in the morning. So what happens, and they were not, ER, not 24 hours, but what happened is obviously when, by the next morning, blood pressure is high. So we just divided. I said, okay, you take whatever, lisinopril at night and metoprolol in the morning, and boom, it's normalized. So you can see, you can maneuver, you can clinically do so many amazing things. And many patients, we were able to deprescribe medications. Because when they come to you and they're like, oh, that's great, they're 120/80 and they're doing fine, and they come in for a cold or something else, you're not going to go sit down and do their, true medication reconciliation. Patient's doing great. Well, if there were 3 antihypertensives, how about, like you said, age-friendly, patient-centered? Well, let's see if we can deprescribe, because, probably not adding much. And then, slowly, like we were able to deprescribe a lot of medication, especially with elderly, they get hypotensive, orthostatic hypotension, they fall, they break the hip. So you want to be very careful. You don't want them to be so low. So again, amazing clinical data, and you get paid for it, which is tremendous.
And with so many, the thing about patients with multiple chronic conditions, they also have multiple providers who are all prescribing different medications, right, and not communicating with each other. So, yeah, I can see this remote patient monitoring being very valuable.
Very valuable, yeah.
Well, is there anything that you want to add to this discussion that we haven't talked about that you think is important for our audience?
Probably, I mean, I think we hit on the high points. I think that everybody should learn and do and provide and bill for CCM or PCM if you're a specialist. I think, adding RPM is huge. And I also, there's one thing that I think as, providers don't do enough of is advanced care planning, which is really cognitive, care planning, really understanding patients' cognitive ability and track, twice a year. I'm passionate about it because both my father and my father-in-law developed dementia, and with my father, I was able to recognize this, but with my father-in-law, I was not, because he was PhD. As we're all aware, the smarter the people are, the more educated, the better they are at masking their dementia. He went from really, taking a bus, going to the library, and coming back with groceries, to passing away in 6 months. And it was only because he wasn't taking his medications. But he was so sharp that we didn't recognize this. So he developed AFib and then CHF, and his Lasix went from 20 to 40 to 80 to 120. His kidney gave out, but we were increasing Lasix without recognizing that he wasn't taking medications at home. So I became very passionate. I, certified as dementia care specialist. And then I've learned that it's an amazing service that is actually getting reimbursed very well by Medicare, brings so much value and just value to patients and their caregivers, and providers. A lot of them are not aware that it's a billable service where you can sit down, do this assessment. You don't have to be a neurologist or psychiatrist. Any primary care can do it. And that's another thing that I'm very passionate about, making sure that providers are aware and actually scheduling patients, because we know patients come in when they're sick or when they're not feeling well, or with like an annual wellness visit. But, annual wellness visit has very, very little thing on cognitive functions. And this is a whole kind of visit on just cognitive function assessment.
Mm-hmm. Good point.
Yep. And I just want to thank everybody that, right now, work through COVID, and chronic conditions are unfortunately, the more medications we have, I feel like we're not getting better as a society. There is a lot of very interesting and cool information that's coming out about actually, the food and exercise and sleep and anxiety. And I'm also very, very passionate about, talking to patients about it, because as a providers, everybody's always kind of, pushed to, see more patients, spend less time, and writing for medication is the easiest and what we think was most effective. And we kind of skip that first lifestyle changes that we should spend a lot of time with patients. And patients need to understand that it is a doctor's prescription, right? It is, exercising and sleeping and breathing exercises. And I've helped so many patients by just incorporating like box of 4 breathing exercises in their routine, and then their blood pressure went down, because it's stress related. So we think of everything as isolated incidents. And with chronic conditions, as a provider, we really need to think of the whole body and mental and physical health as one.
Yeah, and I always tell my patients, because I'm really focused on physical functioning in spine and orthopedics, but which I also consider, palliative care, because it's symptom management, but it's also improving patients' function. But it takes a team, it takes a city, it takes a village, to take care of a patient and to make sure that we're meeting all their needs. So, Irina, this was a very good presentation. We hope to invite you back in the future, and thank you for all that you do.
Thank you. It was my pleasure. Thank you so much.